Yeah. Good evening. So we are starting this week's session on short certificate program on infectious diseases. I sincerely thank APA and ICP for giving this opportunity. And we are completing the first approach to infectious diseases in the first module. And outpatient settings, the second module also has been completed. Now we are in the third module of inpatient settings. Particularly, we have finished selections of antibiotics and approaching infections in hospital-based patients. ICU antibiotics is covered. So this week we are covering about uh, how to approach sepsis in your practice. This is a practical session, so we are doing it. As usual, our routine thing, the speaker will brought presentations of 35 to 40 minutes, followed by whatever questions you are posting it. Your Q&A can be answered. And finally, we got a small post-test question presentations at traveling today. If my signal is not good to this basic room, please don't put your name. Please always ask your questions and get attendance. That's a standard dictum in this program. You need to get attendance means you need to ask the questions or you need to put some your suggestions or your discussions points in the Q&A instead of a chat box, instead of putting your name and getting the attendance. Please ask questions, participate in the polling questions, get the attendance, not putting your name with the attendance. That's what we are insisting to you people. So without further ado, I'll introduce the speaker of session today. Today's speaker is Professor Dr. Vikas Suri. He's a professor, Division of Infectious Diseases, Department of Internal Medicines at PGH Chandigarh, prestigious institutions. And he is a pioneer in establishing infectious diseases fellowship in PGH Chandigarh. And he has got a lot of publications also. And he has completed his infectious disease fellowship from UK in 2015 and 2016. And is a popular speaker also. Without further ado, I'll ask Dr. Vikas Suri to share his presentations and start the presentations. Please ask your questions whenever you start presenting it and take part. And whenever you put your polling questions, please answer the polling questions so that your attendance will be monitored. Thank you for accepting our invitation, Dr. Vikas, in short notice, and you are doing accepting our invitations. Thanks for your acceptance. Please go ahead.
Thank you. I hope my slides are audible. Sorry,
Yes.
visible.
Yeah, slides are visible and you're audible.
Yeah. Well, thank you, Dr. Suresh, for inviting me here, and thank you, the Academic Committee of ICP, for giving me an opportunity. It's always an honor to be associated with ICP. Well, the topic given to me is today's sepsis. Well, it's probably the textbook of Harrison or any other infectious disease textbook, which can be covered in probably the next 35 to 40 minutes. I'll try to finish it in 35 to 40 minutes and answer all your questions. So what is sepsis? Well, sepsis most likely is because of infection and is secondary to a dysregulated immune response, which leads to life-threatening organ dysfunction, and finally, which is called as sepsis. It's a global problem. WHO has declared as a global health priority, and if not identified early, it leads to a very high mortality. Before I go to the various management and the various aspects of sepsis, I wanted to talk about some facts about sepsis. The first one is the sepsis scoring systems. When I was a resident, we used to use Apache and Glasgow Coma scale as possible scoring systems when I was a resident. Well, we have moved over to the news and the news 2 scoring systems. COVID introduced about the MUSE, that is the modified early warning score, which helped us a lot during the COVID times. Well, QSOFA was thought to replace Apache because it was much simpler, and the bedside or the QSOFA, which incorporates 3 parameters, that the respiratory, systolic BP, and altered status, was probably a bedside parameter to identify patients who are at high risk of adverse outcomes, so they can be shifted to a higher center or a high dependency unit or an ICU. The second thing I wanted to discuss is what are the various definitions for sepsis. We have moved from an era of sepsis, SRS, where sepsis with hypotension, and SRS is no longer included in definition by the various societies. And the 2 definitions now are sepsis and septic shock. Well, sepsis is defined as a life-threatening organ dysfunction caused by a suspected or proven infection with a Q-SOFA score of 2 or more from baseline. And septic shock is sepsis with a requirement of vasopressor to maintain a mean arterial blood pressure of more than equal to 65 millimeters of mercury and a serum lactate of more than 2 millimole per liter despite adequate fluid therapy, which is very important. Despite adequate fluid therapy, these are three components of septic shock. Pathophysiology. Well, bacteria are the most common pathogens. Gram-positive, most common in developed countries. Gram-negative sepsis in developing countries like India. Fungal and viral sepsis is increasing. Tropical fevers are a major causes of infection, which are superadded by bacterial infections in this Indian subcontinent. And 50% of patients who are admitted in ICU have a nosocomial infection. And a culprit organism is identified only in 50% of patients with sepsis. That is, 50% of the patients with sepsis we might not be able to isolate an organism. Well, ICMR comes with yearly patterns for antimicrobial resistance, and it tells you the various isolates from the different parts of the country. There are about 10 centers which collect data. And this is a data from 2020 to 23. There's another one which has been published about 3 months back. And these are various isolates organisms. And the top 5 isolates organism in the wards were E. coli and Klebsiella, while the ICUs were most common isolates isolate were Acinetobacter, Klebsiella, E. coli, and Pseudomonas and Staph aureus. What are the prognostic factors? Well, there are 4 phenotypes, and which depends on the level of organ dysfunction. And with the increasing level of organ dysfunction, the mortality increases. The highest mortality is known to occur when the source is unknown. GI infections, pulmonary infections versus UTI performs relatively better in sepsis outcomes as compared to the GI infections. Nosocomial infections, MDR pathogens are associated with bad prognostic factors, and late antibiotic initiation we'll be seeing in the subsequent slides, and failure to aggressively restore perfusion early are one of the most important factors for bad outcomes after sepsis. Well, sepsis management is not one person's game. It's a teamwork. We're starting from the lowest healthcare worker to the highest healthcare workers involved. There were sepsis guidelines, and every society of a country has its own guidelines. But I will be following the 2 main guidelines, that is Surviving Sepsis campaign, which has a very robust history since 2002. When I was in my residency, I had reviewed 2016 guidelines, and now today I am presenting the 2021 guidelines, which were published in 2022. Indian Society of Critical Medicine has published their own guidelines, especially which have some role in resource-limited countries like the Indian subcontinent. So I'll be majorly talking about the Surviving Sepsis campaign and also talking about the guidelines from ICCM. Coming to the Surviving Sepsis campaign, the 93 recommendations, I'll be talking about the main recommendations. I'm touching on the most of the which are pertinent to clinical practice. And I would say that guidelines cannot replace the clinician's decision-making capability, which is a bedside art which every resident or a clinician should not forget. So I would say touch the patient. Don't believe in no-touch technique. As per any guideline, you have the types of statements. The strongest is the best practice statement, then becomes a strongly graded, that is recommended, then becomes we suggest, and there is no recommendations when the data is not there is insufficient evidence to support that statement. Coming to the first one, with the Surviving Sepsis campaign recommends against using Q-SOFA as a single screening tool for sepsis or septic shock. Well, the studies have shown the rationale behind is that it has a low sensitivity. With this study, which was published in Annals of Internal Medicine, Q-SOFA was associated with a low sensitivity as compared to the SIRS criteria. And the specificity of the though the specificity of the SRS criteria was lesser, but the sensitivity was more than QSOFA. Another study by Rodrigo found that QSOFA outperforms SRS in predicted mortality, but the SRS criteria are more sensitive in diagnosing sepsis as compared to QSOFA. But this study by Vincent et al., in which they tried to compare the news and the QSOFA as a predictor for referring patients or transferring patients to the intensive care unit, and they found that news outperformed QSOFA, and the sensitivity of news, that is a news score of more than 8 or QSOFA more than 2, the sensitivity of news was much more than that of QSOFA. Another study by Seen et al. This is the identification of sepsis. Again, the news outperformed the QSOFA. The sensitivity of QSOFA was quite low, but the specificity, that is true negativity, was relatively higher in the QSOFA as compared to other scoring systems. Coming to the second part, that is early goal-directed therapy, and it is a well-known fact that each hour delay in the treatment reduces sepsis survival by 7.6%. Though many guidelines say that sepsis burden a golden hour, but now data is coming that by protocolizing sepsis management, sometimes we overdo the management, but it still is the golden hour still remains time when tested. This is the 1 hour bundle. It is, if you have the facility to measure lactate, obtain blood cultures within the first hour. And I'll be talking about the other 3 components, that is antibiotics, vasopressors, and the administration of fluids in my later slides. The arterial lactate levels are preferred over the venous ones for ease residents in the VBGs, but the arterial lactates are preferred over the venous lactates. What about the blood culture? To blood culture, if you're taking from a central line, then always take it from a peripheral site, from a separate site. Try transporting the culture bottles as soon as possible to the lab. If not possible, never refrigerate that bottle and leave it at room temperature. Coming to the other 3 bundles, they are the administration of antibiotics, the fluids, and the vasopressors, which we'll be talking about my later slides. Well, the cornerstone of management of sepsis, if you have to sum it up in one slide, is early installation of antibiotics and IV fluids and vasopressors. That is, if the maintenance of the adequate mean arterial pressure. So the third recommendations by the Surviving Sepsis Campaign is that it suggests, but it not mandates, measuring lactate as a screening tool for sepsis. Well, this study by Brian et al. In 2017 evaluated the 3 biomarkers for sepsis, that is lactate, leukocytosis, and procalcitonin, and they found that predicting lactate level of more than 2 millimole predicted sepsis as better as compared to the leukocytosis and procalcitonin. Similar results were found in predicting septic shock, and lactate outperformed the leukocytosis and procalcitonin. There are many markers, biomarkers in which have been studied, but lactate has probably stood the test of time, and at this moment it is the recommended one. Coming to IV fluids, we know that there are crystalloids and colloids. Well, crystalloids include the normal saline, ringer lactate, and 5% dextrose, and the colloids includes albumin, the gelatin, and the starches, and the dextrans. Well, this is the comparison. A normal saline has an osmolality of 308. It has a sodium on 154, while a dextrose has an osmolality of 252, and it has high glucose. Normal saline has its own complications like hypochloremic hyperacidosis, and nowadays it is not preferred as a resuscitation fluid. When I was a resident, this was the resuscitation fluid which we used to use. Then we have ringer lactate and a ringer lactate solution, where the osmolality is 273, and you have a sodium of 130 and a potassium of 4, but it contains lactate in about 28 milliequivalents per liter. Then we have a ringer solution or a balanced fluid, which I'll be talking about, in which there is no lactate. The colloids includes the albumin and the starches. Well, they have potential side effects in form of allergic reactions and a tendency to cause renal dysfunction and coagulopathy, which inhibits their use in sepsis. So coming to a balanced IV fluid, that is plasma light, which is the recommended now. I'll be talking about my later slides. What is a balanced IV fluid as comparing to normal saline ringer lactate? The sodium content is lesser as compared to the normal saline. There is no lactate, and we have gluconate, and it simulates the patient's plasma in forms of the ions. That is said, a measure of that said is known as when we measure between the patient's sodium and the chloride concentrations. So it probably simulates that thing. So coming to the fifth recommendation, the volume of fluid to be used. Well, Sespsis campaign recommends that we use at least 30 ml per kg IV crystalloid should be given in the first 3 hours. So how did the 30 ml per kg IV crystalloid solution came? Well, this is from this study in which they found out that the ICU losses, the delayed hypotension, mortality, intubation, all were best performed when 30 ml per kg as IV crystalloid was given. At both lower and higher one did not make any significant difference in the O. So fluid therapy generally administered in boluses, that is 500 ml, and before you give the next bolus, always look for pulmonary edema. Well, there is a role of restrictive strategy versus the liberal strategy. But the restrictive strategy is a maintenance IV fluid and vasopressors, while liberal strategies is boluses with maintenance fluid, and the 76 happen does not actually suggest that a restrictive strategy with vasopressor is better than liberal strategy with or without vasopressors. Coming about crystalloids versus albumin, it's a strong recommendation to use crystalloids. This is the study which, though had some albumin, was nearly comparable to crystalloids, but this meta-analysis showed that crystalloids were associated with less complication, that is less need of RRT and coagulopathy as compared to colloids. Hyperoxia and hypertonic saline, there was some data that if you increase the oxygen and give hypertonic saline, there is some role in sepsis. But this HyperS2S trial, which showed that it had to be stopped early because increased mortality was seen in the hyperoxia and the hypertonic saline group, and significant adverse effects were seen in patients who were given hypertonic saline and were given super oxygen concentrations. So in addition to the additional risk of hypochloremic metabolic acidosis, renal vasoconstriction, increased cytokine secretion, and the concern about acute kidney injury makes normal saline not a preferred fluid for resuscitation in sepsis. There is some role for albumin, especially patients with cirrhosis, where when albumin, it was shown that albumin outscored normal saline in maintaining a MAP of when the MAP was less than 65 millimeters of mercury. So Survivor Sepsis campaign suggests using albumin in patients who receive large volume of crystalloids over using crystalloids alone. So if you're using a large amount of fluid, it is suggested that you may add albumin in a certain subset of patients. What is the data for use of balanced fluids? Well, there is ample data that balanced fluids outperform normal saline in both in terms of mortality and need for RRT. But there are certain studies, that split trial, the SALT pilot trial, with phase shown benefits, and But Sespsis campaign recommends balanced fluid use in resuscitation fluid. The use of starches is strongly not to be used, and the basis for this is this trial, that is the HS trial, in which both the starches were associated with increased risk of need for renal replacement therapy and coagulopathy as compared to ringer patients receiving a ringer lactate. So they're not recommended as resuscitation fluids in patients with sepsis. The same data comes from the Cochrane review, in which they found that starches, dextrans, and albumins versus had little to no difference in mortality. Starches increased the need for blood transfusion. There was no difference in RT use with albumin or FFP, and the need for blood transfer, dextrans, and albumin is uncertain. But starches and the colloid should not be used as a resuscitation fluid for sepsis. So how do you monitor? You've given fluids. How do you monitor? Conventionally, we measure the urine output, heart rate, respiratory rate, skin color, temperature, pulse oximetry, and mental status. Well, a bedside parameter, that is the mean arterial pressure, if you maintain more than 65, is a rough bedside parameter, and it's very studies have proved that maintaining a mean arterial pressure of more than equal to 65 millimeters maintain perfusion and decreases mortality. Well, there is a certain other parameters which are known as the static or the dynamic parameters. The static parameters include the central venous pressure, the wedge pressure, measuring the cardiac output, systemic vascular and peripheral vascular, pulmonary vascular resistance. While the dynamic variables are a little difficult to measure, they are possible only in ICUs and where specialized and they need specialized training. But Sespsis campaign recommends that it is better to maintain a mean arterial pressure of 65 millimeters of mercury. Well, how does 65 come? Well, this is study which was published in NHGM, in which they divided the patients maintaining a blood pressure of more than about 85 versus 65 to 70. And they found that no significant difference in mortality in patients who maintained a higher MAP as compared to a lower MAP. But the adverse events also did not vary. But the incidence of new onset atrial fibrillation was more in patients where the MAP was above 60, above 85. So that is why the number of maintaining a MAP of more than 65 has come. Well, the Surviving Sepsis campaign suggests using dynamic measures to guide fluid resuscitation over physical examination or static parameters alone. So wherever you have the facility, use these dynamic measures, which all the major ICUs are doing now. So is there another way we can tell what is the duration of fluid resuscitation? Well, there are two parameters which are compared. That is the decrease in the serum lactate. If you see the sepsis bundle, it was written that you remeasure the lactate after 6 hours. And this multicentric trial showed that remeasuring lactate and decrease in lactate was a very good marker in helping fluid resuscitation. Well, this trial compared the capillary refill time versus the lactate group, and it was in patients who had higher lactate levels after fluid resuscitation had higher mortality levels. So lactate decrease in lactate was a better marker in helping in fluid resuscitation targets as compared to capillary refill. Coming to use of vasopressors, well, these are various vasopressors which includes norepinephrine. When I was a resident, we used to use a lot of dopamine and dobutamine especially patients who had cardiac dysfunction. Norepinephrine had just come when I was doing my residency, but now it is recommended to use norepinephrine as the first-line agent over other vasopressors. Well, this data comes from the SOAP trial. Though dopamine versus the norepinephrine, the mortality was comparable, but more arrhythmias occur in the dopamine group as compared to the norepinephrine group. For non-responders who are not able to maintain MAP levels, it is suggested to add vasopressin instead of escalating dose of norepinephrine. Well, this data comes from the VAST trial, which recommends, and it is generally recommended that vasopressin should be started when the dose of norepinephrine is in the range of 0.25 to 0.5 micrograms per kg per minute. Newer drugs like telemedicine have no role in management of sepsis, and though in patients who have septic shock or cardiac dysfunction, dobutamine may be used, but it should be stopped as when the required MAP is maintained and the target is achieved. There is no role of levosidomide. It is a calcium stimulant. It stimulates the calcium and helps in management of heart failure. And there is no role of role of this use of this drug in management of sepsis. So if you see what is the how the vasopressors are used, first use norepinephrine. The target MAP is about 65 millimeters of mercury. Consider invasive monitoring if you have the facilities. If central access is not available, if you're not able to maintain a MAP, consider adding vasopressin. If cardiac dysfunction is sepsis-induced cardiac dysfunction is there, you may add dobutamine or may switch to or may add epinephrine also. Coming to antibiotics, which is one of the most controversial and the most abused part in management of sepsis. Well, the golden rule is if shock is present, administer antimicrobials immediately, ideally within 1 hour. But if shock is absent, you may ideally, yes, within 1 hour, but you may send cultures but still antimicrobials should be administered within 3 hours. Well, the Surviving Sepsis campaign recommends addition of MRSA targeting antibiotics as an empirical antibiotics because this data comes from the West, and these are high-risk groups which are risk for MRSA. While it recommends using 2 antimicrobials gram-negative coverage when when there is a risk of multi-drug resistant organisms, and these are various risk factors for occurrence of MDR organisms. This is what we use in our hospital in the various organ-specific infectious syndromes. This is the empirical antibiotics when we were able to localize in the first few after clinical examination with the empirical antibiotics which we start in our. But all these are based on our local antibiograms, and in hospitals where antibiograms are available, or you may see the ICMR surveillance data in helping you guiding your antibiotics in your area. A word about procalcitonin. It has a sensitivity of about 77%, detectable within 2 to 4 hours of infection, peaks within 6 to 24 hours. Lot of false positives and false negatives. And accepted cutoff levels are PCT level of 0.25 milligrams per liter in non-critically ill patients and a level of 0.5 milligrams per liter in critically ill patients. Well, there are various algorithms. It came as a bang that it may help us in initiation of antimicrobials, but the best evidence is that it helps in de-escalating antibiotics rather than initiation antibiotic. So I would say procalcitonin helps us in the resolution of infection. It may help us to de-escalate rather than the initiation of antibiotics. Well, Sespsis campaign also suggests again using procalcitonin to decide when to start antimicrobials. It suggests using procalcitonin and clinical evaluation to discontinue antimicrobials over clinician's evaluation alone. So it is whenever using antibiotics, there should be a daily assessment, and whenever you have this specific mechanism, the antibiotic should be modified and tailored according to the infection etiology which has been isolated. It is suggested to use shorter regimens than the longer regimens. Well, coming to fungal sepsis, as we all know, these are various types of funguses and various types of infections. And the most common, most dreaded one are the invasive fungal infections, which data shows that it is one of the foremost challenges to an intensivist in ICUs. We have evidence for that. Coming to the ICMR data, fungal infections constitute about 3% of all the isolates. Candida is the most common fungus isolated from the ICUs, and the most common was Candida tropicalis, followed by Candida albicans. What does the SSC guidelines say? It says that patients who are at risk, well, these are the risk factors for candidemia and the risk factors for yeast and molds, we should suggest using empiric antifungal therapy over no antifungal therapy upfront. But in patients who are at a low risk of fungal infection, we should not use empiric antifungal upfront till we have some evidence of fungal infection. Well, the empirical study which compared empirical micafungin versus the standard treatment did not find any advantage in the low risk group when antifungal was added empirically. So I would say there is no role of empirical antifungal if there is low risk factors group. Coming to source control, it is one of the most important aspects in managing sepsis. Always try to find and source control by appropriate imaging techniques and thorough clinical examination, especially in patients who have pyomyositis and a daily examination is warranted in this subset of patients. Coming to ventilation, there is sufficient data to recommend conservative oxygen targets. Well, as compared to well, studies have shown that when conservative approaches were used, the ventil-free days did not differ in patients who had in which a higher oxygen level was maintained, and the 180-day mortality was also the same. There are various oxygen delivery systems which range from nasal cannula to non-rebreather mask to venturi mask. COVID told about the use of HFNC, and finally you have the ventilation with intubation. What about HFNC? We have to set two parameters, that the flow rate and the FiO2. First, set the flow rate and then set the FiO2 to the required. And if there is no improvement after 1 hour, consider escalation of therapy to the next level. So what are the surviving sepsis campaign use? It suggests use of high flow oxygen over non-invasive ventilation if hypoxemia is present. This was the HFNC over non-invasive ventilation. Well, this was the Florali trial in which though the 90-day mortality was there was substantial difference in patients who had used the HFNC as compared to the non-invasive ventilation. So HFNC is preferred nowadays over non-invasive ventilation in patients who have a hypoxemic respiratory failure. Low tidal volume, plateau pressures of 30 centimeters of water, high PEEP over low PEEP are preferred modalities for ventilation when you are ventilating patients with. I'm not an expert in ventilation, so these are the parameters. We always take the help of our intensivist in ventilating our patients. Traditional recruitment maneuvers over incremental PEEP strategy should be used. And prone ventilation, again, we use a lot during COVID times. Moderate to severe ARDS, prone ventilation for more than 12 hours is strongly recommended. Use of neuromuscular boluses is preferred over continuous infusion, and this data came from the Rose trial, in which the boluses outperformed the continuous infusions in time. A word about use of steroids. It is very controversial. When in 2016 they said abundantly no to use of steroids, but this data from this trial showed that use of hydrocortisone and fluorocortisone combination both showed a mortality and a resolution of shock benefit when used in the doses of 50 milligrams, that is 200 milligrams in 24 hours. So what we do is we give 50 milligrams every 6 hourly. It is generally said that it is commenced at a dose of norepinephrine and epinephrine when it is at least above more than 0.25 micrograms per kg for at least 4 hours of reinitiation. The duration is generally said to be 7 days or until intensive care unit discharge. We generally give it for 7 days because prolonged steroid use may lead to hyperglycemia and increase infections. Need for RRT in patients who require RRT, continuous or intermittent replacement therapy is preferred. The techniques are preferred over the hemodialysis. This came from the Ideal ICU trial, in which this modality of RRT outperformed over the conventional hemodialysis. Blood transfusion, a restrictive approach that is maintaining an HB of between 7 to 9 gram per deciliter had outperformed liberal blood transfusion, in which the levels were maintained about between 10 to 12. It led to less adverse events. A word about treatment of metabolic acidosis. Well, it is said bicarbonate only to be used if the acidosis because of sepsis and if the pH is less than 7.2 and there is renal function present. But if the shock is there and we have not started IV fluids, then there is no role of bicarbonate therapy. First, we should initiate fluid resuscitation and then only add a bicarbonate therapy. Other supportive measures, ICU admission for all sicker patients as soon as possible. Initiating insulin therapy at a glucose level of 180, it's still controversial. Many studies have shown a lower glucose level may increase, have some mortality benefits. Early initiation of enteral nitration, use of VT prophylaxis unless a contraindication, that is, and low molecular heparins are preferred over the conventional heparins. So this was a nutshell about the various surviving sepsis campaign guidelines. And coming to the last leg of my talk, that is some guidelines, some recommendations by the Indian Society of Critical Care Medicine. Well, most of them are in accordance with the surviving sepsis campaign, but I will probably telling you the differences. Well, consideration of diagnosis of sepsis, most of them are same, but they say that CRP is more feasible to measure because lactate is expensive and may not be available in many of the ICUs in the Indian subcontinent. And the possibility of tropical infections be considered in evaluation of sepsis, which the surviving sepsis campaign did not mention. Management, especially who patients are awaiting ICU bed. This is more or less in accordance with the surviving sepsis campaign guidelines. In the management, the clinical parameters, the resuscitation fluids, use of vasopressors are in accordance with that of this SSC guidelines, but they recommend empirical antiparasitic agents in a suspected sepsis of parasitic origin. This is keeping in mind the increased malaria which is there in the northeastern part of our country. So in the end, I would say sepsis skills recognize, resuscitate, and refer early, and it leads to decreased mortality. Well, thank you very much for a patient hearing.
Thank you, Dr. Vikas, for wonderful negotiations. You touched almost all the aspects of the sepsis, from fluids to the ventilation to diagnosis part of CRP, procalcitonin, everything you touched about it. And most important thing, antibiotics is also played. A lot of questions already in the chat box. What I do for a change today, I start the post-test questions. Meantime, we go through the questions posted in the chat so we can have the discussions towards the end. I ask the post-test questions right now to the participants. Then we'll discuss the FAQ and try to finish by 8:30 there. That's the plan. We just go through a lot of questions there, lot, particularly fluids. They're asking about newer modalities, everything they're asking about it. So this is a post-test questions because he put a lot of theory there and put some of cases for you people to answer right now. So this questions answers only will consider your attendance. Please speak. Those who want to get the attendance, please start answering the questions posted here. Okay, so this is a 52-year-old female from Odisha, basically diabetic, fever, headache, and confused. On examinations, tachycardic, tachypneic, BPs, and hypotensive. Respiratory system examination showed crackles, some stiff necks, doubtful is there. The deep tendon reflexes were sluggish. Our platelet count was 45,000. How many say does this patient is septic? Say yes, no, maybe, I don't know. Despite having a good 35 minutes to 40 minutes of lecture on sepsis and a lot of guidelines, what do you think about it? Or start antibiotics. So I want the answers for the chat box. So I think almost 98 people still alive. So just go ahead and answer so that we can have discussions towards the end. Okay. People say yes, start antibiotics. So they don't want diagnosis, they want to start antibiotics. Good. Okay, people say this is septic. Okay. People say I don't know also. Maybe. Okay, good. So a lot of participation is happening. Good, keep answering. So those who are answering definitely get the attendance today. Don't worry about the attendance. Okay, sure. So what is sepsis in short? This is how William Hostler defined. Sepsis means SIPO or rot. Something is getting rotting up. Something rotten up in your body is called sepsis. And he clearly told the infections is not killing the patients. The body's response to the infection is killing the patients. That's what he defined a lot of centuries back. This is William Hostler's definition of sepsis. And if you come back to the 2016 or 2021 regulations, life-threatening organ dysfunctions due to the dysregulated host response. I got a lot of reservations for these guidelines. I'll come back what you need to do. This is a guidelines what Dr. Vikas has clearly discussed about how the guidelines are discussing about the sepsis. So coming back to this case now, if you say people answer this case is sepsis to you, what sepsis this one? SARS, sepsis, severe sepsis, septic shock, some infections, start antibiotics. Keep answering now. So the same case to you, but people answered. Some people say septic shock also there previously, but now you need to answer what is your diagnosis now. To be specific, you said sepsis. So now you need to answer. I think 14 were answered. People are saying, just come back. They're saying sepsis. Okay, keep answering. So people are saying there are sepsis. I just want to go back to the chat 1 minute and come back to the answers. Septic shock. Okay. All sorts of answers coming up. Unfortunately, input. Some people answered SARS also there. Very interesting. Good. Okay. So this is how now previous definitions. What is happening in 2016? Previously, we defined 4 terms: SARS, sepsis, severe sepsis, septic shock. Now 2 entities has been removed. One is called SARS is gone and severe sepsis is gone. So you need to say whether the person is sepsis or septic shock. How to say sepsis according to the guidelines? Suspected or documented infections by defining SOFA score of more than 2 points. Or septic shock means presence of sepsis plus vasopressor therapy or lactate more than 2 millimoles per liter. So this is how the definition is going on. This is Sepsis 2013 guidelines. But what is a what is a SOFA score? Not Q SOFA score. This is a SOFA score. For example, when the FiO2, particularly the PaO2 by FiO2 ratio is going down, the points can go up, and the hypotension's requirement is going up. One parameter is called platelet count. For example, this patient has got initially the platelet count of 1,50,000, now dropped to 45,000. Can you call this patient has got sepsis according to the SOFA score? Because initially the patient's platelet count was 1,50,000, but now 45,000. If you put the scoring alone, patient has got more than 2 SOFA score. When the person has got more than 2 SOFA score, the person is sepsis to you there, correct? Okay. So why a lot of confusion is happening in sepsis? Basic reason is there is no much research is going on. A lot of money is going to the stroke, a lot of money is going to the heart attacks, a lot of money is going to the cancers and other thing. But unfortunately, sepsis, the money is not coming up. That is the reason a lot of confusion is going around. So I'll show one more thing there. This is a diabetic, recent STEMI thrombolized also. Underwent CAG and 2 stents. Now post CAG and post PTCA, he got fever, tachycardic, mild hypotensive, WBC count gone up, polymorph predominant. Blood culture is 1 out of 4 GPC. What will you do now? Call the microbiology lab, ask for the blood culture identification panel, or start vancomycin because of the GPC, all of the above or none of the above. What will you do now? Please answer. Those who want real answers, please go ahead. So I want to check how many people want to do. So this one people want all of the above. They want to call lab, they want to do BCID, they want to start Vanco also. People say all of the above. I'm looking for 1 of 5. That's very interesting answers. None of the above. Good. Okay. Very good. 1, 1, 4. Okay. Mostly all of the above. That's good. Interesting. People are answering now. So that's very interesting. Okay. Good. So this is previous classifications I told. SARS was there, and now Dr. Vikas has clearly mentioned about what is the role of QSOFA score and SARS scoring system. So right now SARS is gone. How many say SARS removed is good for nowadays? It's appropriate. Removing SARS in 2016. Choice 1 is appropriate, choice 2 is inappropriate. Whether if we are removing SARS from a definitions of the 2016 guidelines, surveillance sepsis guidelines, they removed SARS. How many say this is appropriate? How many say no, SARS should be there? Why they removed the SARS? I want your participation now. This is provocations. People say it is appropriate, people say it's inappropriate. So a lot of appropriates and inappropriate. 50-50 we can put it right now. Appropriate only, SARS removed is good. But as an ID doctor, it's a bit difficult to say it's appropriate or not. SARS is an appropriate response. Sepsis is a dysregulated response. But how will you quantify the dysregulated response? Can anyone quantify the dysregulated response? Here the person has got post-CABG, not post-CABG, post-angio, post-myocardial infarction. Myocardial infarction per se can cause some elevations in the fever, elevations in the WBC count. Second thing, the person underwent thrombolysis. Third thing, the person underwent angiogram, the dye was injected and PTCA took some time. So all this can cause fever, elevated WBC count, mild tachycardic and mild hypotension because of the low cardiac functions. So this is typical SARS term. If you write SARS, I don't write antibiotics. So removing SARS term can increases antibiotic abuse. As an antibiotic steward, this is a worrying trend for us. So for us as an antibiotic stewardship, if you write SARS, for example, major surgeries, fever can happen, WBC count can go up. Pancreatitis, again, WBC count can go up, fever can happen. Burns, this can happen. So for these situations, don't write antibiotic, provided if you write a diagnosis of SARS. That's interesting. But unfortunately, 2016 guidelines has removed SARS. That's a big problem for us as an antibiotic stewardship. It increases antibiotic abuse. This is a normal response of the body to any stress, whatever stress, whether infection or non-infections. Most of the time, SARS is due to non-infections to me. So coming back to this case, people who voted sepsis, now the malarial parasite came back as positive. Can you call the person has got sepsis or the person has got malaria? I wanted the answers from you people. Please go ahead and vote. What is your choice now? How many say this person has got sepsis or the person has got malaria? Why I'm critical of 2016 guidelines of surveillance sepsis guidelines? These are all the reasons. One, how to quantify the dysregulated response? I'm not sure about it. Second thing, they're removing the SARS. SARS lead to removal of antibiotics, abuse of antibiotics. People say this is malaria, give anti-malarial. Don't talk about sepsis or severe sepsis or septic shock. So the question here is whether the tropical infections, for example, most of the sepsis, surveillance sepsis guidelines is based upon respiratory tract infections data, but they don't have a tropical infections data like malaria, dengue, or even your strep typhus. The data is missing, leptospirosis, even viral fevers like flu, COVID. Everybody knows it. Right now, COVID is also emerging now. So these things can cause sepsis pictures. So these things also can cause sepsis. But unfortunately, surviving sepsis guidelines 3 does not mention what organism is causing sepsis. They do not define dysregulated response. They removed SARS. it doesn't mention about organisms causing sepsis. All Western data, there is no tropical infections mentioned. They think about bacteria. Rarely they include Candida as an etiology, but unfortunately they didn't mention about any bacterial stuffs like or parasites like malaria or strep typhus or leptospirosis. This is a big challenge for us. So that is why the surviving sepsis has got a lot of limitations. One, the new definition is not well studied because this is not a universal population. Selected Western data with minimal respiratory infections as a major source, difficult to quantify the dysregulated response, no mentions of etiology, and almost all the scoring system. One of the scoring system, people are asking which scoring system. We'll have an FAQ discussions during the time. No mentions on etiology. If you look at the Western data, always, this is mostly bacterial. Even the recent publications from India, the mass data that showed clearly tropical infections is the leading cause of sepsis in developing country like India. And off late, viral infections can cause sepsis pictures like influenza, COVID, everything can be heavy. So how to define? Criticism is easy. And can criticize the surviving sepsis guidelines is easy for me. Sepsis means for me is a bad infections or serious infections. In one term, you can say this is a serious infection, dysregulated everything. If you ask somebody what is sepsis, serious infections or bad infections. How to define serious sepsis? What individual has got sepsis? For example, what predisposed the individual to got sepsis? What sort of immuno status the person is having? Immunocompromised, diabetic, poorly controlled, lot of hospitalizations, community acquired, hospital acquired, what Vikas was mentioning about it. Where is the infection? That's most important thing. What is the response of the body to the infections? Tachycardia, hypotensive, fever, and what organs are affected? That's most important thing. What is the organ is affected? So we need to know what predisposes. This is called the PICO approach. What predisposes? Where is the infections? What is the response of the body? What organ failure? We need to think about it. And we need to always think broad differential diagnosis. Don't think when a person has got fever, when the person has got elevated temperatures, tachycardic, don't think the person has got sepsis. For example, when a person has got fever, shortness of breath, don't think the person has got pneumonia alone. Pulmonary infections and embolism also can behave. Similarly, when the person has got pain, abdomen distension, and fever, don't think the person has got only abdominal sepsis. Pancreatitis also can behave this way. So coming back to my couple of last more cases, diabetic 38 female, cough, headache of 7 days durations. Now worsening respiratory distress, confused, tachycardic, hypotensive, tachypneic, thrombocytopenic, elevated AST, creatinine is high, acute kidney injury, X-ray shows infiltrate. What's your diagnosis now? You say tropical infection is causing the diagnosis. Please go ahead and answer. What is the diagnosis? It's a bad infection. You can put this is sepsis, bad infection to me. I want to see the responses. How many people are saying? So people say this is septic shock. People say this is tropical infections. Now understood, tropical infections also can cause sepsis. That's a good thing there. Good. So what do you think? So what do you need to define here? I told the PICO approach. Apply the PICO. This is a diabetic host from rural part is coming back, and the localization is possible respiratory system, possible meningeal system. Both the respiratory and meningeal system, tropical infections, one of the differential diagnosis. So what you need to say, what predisposes young diabetic, maybe poorly controlled diabetic. That's the reason for getting infections or serious infection. The source of infection may be respiratory system, maybe brain, maybe tropical infection is possible. What is the response? Tachycardic, hypotensive, elevated WBC. What organs are affected? Because the confused brain may be involved. Person is tachypneic, so the lung involvement is present. Hypotensive, cardiac involvement, acute kidney injury, and low platelet. Almost all the 5 organs, according to the SOFA system, is affected now. So he's got a serious infection. That means the person has got shock also. So this is what we need to think about it. So PICO approach, you can apply this case. And where is the infection? Rule the syndromic diagnosis. Fever, cough, shortness of breath, pneumonia, fever, altered mental status, seizures, meningitis. We need to think about it, these things in your practice. Then we need to test appropriate. You clearly mentioned about it. Blood cultures has got value. Send appropriate blood cultures volume. 2 sets minimum required. And what is the role for the newer thing PCRs? Yes, it has got role, but interpretation is always difficult. And we need to identify the sick host. So we need to use some scoring system. Ideally, what we need to do, neutropenic host, newborn, elderly people, taking some immunosuppressive, always the threshold is bit low. So that we need to remember in mind. So this is last case, post gallbladder. So person has got a gallstone, post ERCP, fever, some mild hypotension, and patient is getting pip. What is your antibiotic of choice? whether you want to continue the piptazo. Despite piptazo, the person has got low-grade fever, BP is on lower side. How many say I want to start even more broad spectrum, or I want to image, or I want to follow the cultures, or latest antibiotic. A lot of things is people are marketing now. So what do you want to do? Yes, yes, we are discussing all the cases here. So I just almost all the cases we answered right now. I'm going to answer. Don't worry about it. So this case for me again post PRCP mild stress. So there is no need to worry about it. So single episode of fever don't react. But unfortunately, people reacting single episodes of cultures keep on sending cultures and keep on reacting. So you need to be judicious in ICU. Don't react. ICU for one fever in a stable patients don't react. Most of the time be cautious, be cautious. So here the person has got one low grade fever post CRCP, already getting decent antibiotic cover. I would wait. Or if needed, I can reculture rather than worrying about starting antibiotic. That's the answer here. People say when to start antibiotic. This paper created a lot of confusions. Within 1 hour, I need to start antibiotic. This is famous Anand Kumar's paper. But now meta-analysis showing if the person is stable, whatever host I told, neutropenic, not a neutropenic host, not a newborn, not an elderly, not an immunosuppressed, you first make a diagnosis of sepsis and start antibiotics. Drugs how to start based upon the spectrum, based upon site of infections, based upon the previous antibiotic. But whatever antibiotic, even for sepsis, the duration is short. Whether bacteremia, neutropenia, the duration is coming down. So diagnosis, the infection is most important thing. Define sepsis as a serious infections. Use PICO approach. That's more important. Send appropriate cultures and appropriate tests. Not everybody needs everybody cultures. Start appropriate antibiotic based upon the spectrum. Short is sweet. I think most of the questions we answered, but Indian patients are paying for the packet. That's most important. Those who want to learn more, this is a tool you can download. You can send your request so that we can include it in their list of IDs. So with this, I can open up the questions already posted there, and we also gone through it. So the first question, Dr. Vikas.
Yes, sir.
So, which is the best screening test for sepsis?
So I think
Screening
so.
tool.
I think so. You've already answered it in your slide. I think
You
so.
also mentioned it there, yeah.
Yes, yeah. So,
So usually, yeah, go ahead.
these you can go ahead, sir.
Yeah, there is no scoring system. Clinical diagnosis, we need to use of it. All the scoring system has got advantages and disadvantages. For example, SARS has got good sensitivity, but specificity is missing. So we are over-diagnosing. So far, again, the sensitivity is good, but the specificity is also lacking. So each one new score has got, again, if you use a SOFA score, I need to get the lab value. At the bedside is a bit difficult. So this is a challenges, but you need to use where is the infections, how severe is the host, what sort of host, that's more important rather than going with the scoring system. Scoring systems only for very limited resources. For example, in OP setting, QSOFA can be used to identify whether the patient needs hospitalizations, whether the person needs close observation. That's what we used to do. All the scoring system has got advantages and disadvantages. Use your clinical judgment. So this one, second thing I want to answer you from your side, indications of timing and giving of steroids and such as.
Sir, it is generally said that you give steroids once you've added there's a definite role in septic shock. No, not in sepsis only. Septic shock, you've added vasopressors, you can add steroids, but the maximum dose is 200 milligrams per day. The duration is said to be 7 days. Some data say that you can give up to the ICU discharge, but 7 days is what we use here. We have to look for hyperglycemia, and with this is so steroids low dose definitely you can use.
Okay.
But some certain conditions like COVID, where the 6 milligram Dexa, and we have sometimes used in influenza also, but COVID Dex 6 milligram Dexa, the regimen is different, actually.
Because has clearly answered regarding the hypotensions, despite vasopressors, if we need, we can use. Follow-up questions, one thing, how long we want to give either hydrocortisone or steroid tapering is required in sepsis?
It is generally said 50 milligrams 7 days, and you can probably stop it.
Actually, up to 7 days, there is no need for tapering. If you are using more than 7 days, then only we need to think about tapering the dose. So when a person has got hypotension despite good vasopressors and some of the adrenal insufficiency situations causing sepsis, yes, and third thing, newer indications like viral infections, particularly corona and even influenza has got a little bit of data. So whether people are asking you, touched about the lactate role, what is the take on lactate from the ABG? Whether we can rely on the lactate ABG?
Arterial lactate levels are always preferred over venous ones, though repeated ABG is difficult to obtain, but arterial lactate levels are always better. So you try to measure it within first 1 hour and then probably target repeat a lactate level after 6 hours. Definitely a level more than 4 millimoles. It is generally said 2 millimoles that the diagnosed sepsis is there, but there is data to suggest that lactate directed fluid therapy has definitely a better role, but then it adds to the cost. I come from a hospital where an ABG costs me around about 100 rupees. But in a setup where the ABG costs you 1,000 rupees or 1,500 rupees, then probably cost would be an issue also. So ideal
Right.
versus with
Yes.
practical issues, I would probably say, but arterial lactate levels are always preferred.
Well said, Naga, because depends upon the Naga, where you're working. That's most important point we need to consider. So how to identify sepsis in the patients with the bone marrow suppression people are asking. Usually bone marrow suppressed patients, neutropenic is a bit difficult to identify. The standard markers like fever, leukocytosis won't happen, neutropenia will be there. But we need to look for organ dysfunctions here closely. Any threshold for organ dysfunctions, you need to think about sepsis there. Otherwise, there is no major differences between bone marrow suppressed rows or bone marrow suppressed rows there. Then yeah, they're asking about indications for albumin in sepsis.
The surviving sepsis campaign says whenever using a large amount of volume of crystalloids, you may use, but in certain subset of patient like cirrhosis, you may use albumin. And rest of they say the albumin has no definite role over the crystalloids.
Always crystallites we prefer over compared
Yes.
to the albumin.
Yes.
That's a resuscitative fluid there.
Yeah.
Then they're asking fluid resuscitations in the patients with the low ejection fractions.
It is always now you have point of care tests, you have the IBC diameters and everything. You can so it is probably you have to as I already said, you may give it in boluses, and before the next bolus you have to look for pulmonary edema. You have various dynamic monitoring device systems in which you can look for pulmonary edema. If the fluid resuscitation and norepinephrine is not working, then you may add dobutamine if it has a sepsis-induced cardiac dysfunction. But stop dobutamine once the target is achieved.
Usually we don't give like a fluid boluses most of the time when a
Yes,
person has got low cardiac
yeah,
function. We give
yeah,
minimal
yeah,
volumes only there.
yeah.
Then they're asking about the role of CRP and procalcitonin. I already touched upon your presentations. Just reinforce people diagnosis.
The Indian Society of Critical Care Medicine, because of the high the availability of lactate, probably recommends the CRP over lactate in its guidelines. But CRP has definite. I would it has the lactate. If you have to compare lactate versus CRP, the lactate probably outscores CRP in my opinion.
So usually you clearly mentioned in the presentations procalcitonin to stop antibiotic
Yes.
is not going to make a diagnosis of sepsis, as clearly
Yes,
mentioned in
yes.
presentations. Then couple of things there. They're asking about why noradrenaline compared to scored over dopamine. Is there any why noradrenaline is preferred over
Well,
dopamine?
the trial showed that the mortality difference was not very much, but the subset which used dopamine had a lot of arrhythmias, a lot of adverse effects. That is why the norepinephrine is preferred over dopamine as a vasopressor in sepsis.
Then they're asking about couple of newer things like ulinastatin, methylene blue, and what is the role of these things in sepsis?
Well, methylene blue, it is said that it decreases the nitric oxide production, decreases the vasodilatation, and helps in decreasing the need of vasopressors. But there are isolated studies. There are more robust data is needed to recommend its universal use in all patients with sepsis.
So there's not studied molecule there, so there's no data. Similarly, people are asking about cytosorb. Again, in Indian setting, cytosorb is costly. We need
Yes.
CRRT, ECMO machines and everything. Bit
There is no
difficult.
uniform to say that that cytosorb has a definite role in management of sepsis, but more data is needed for that. Again,
Yeah,
cost is
correct.
the issue.
Yes. And people are asking about why plasma, what is the advantage of plasmolyte in sepsis with acute kidney injury?
Again, acute kidney injury, you have to give your fluids according to the probably the urine output and everything. Plasma light. I asked the same question in an ICSM. They say that though there is no lactate and plasma light is quite safe in patients who have acute kidney injury. Even ringer lactate, they say, because the volume of ringer lactate which you're using in renal failure is quite low. But if you have plasma light available, then give plasma light. Normal saline, we in our hospital generally it's a matter of demand and supply. So the plasma light, again, from where you are coming, I would say.
Since we already overshot it to 8:34, 8:35, I told 5 minutes only overshot. Lot of questions is coming up. Couple of things I answer quickly there. People are asking about what is the best antibiotic in HIV with sepsis. Whether HIV or immunosuppressed, use a PICO. Where is the infections? Depends upon infections, depends upon the resistance pattern, depends upon the spectrum used. What is the best antimicrobial for gram negative? All depends upon where you are working, what is your resistance pattern, what is your infections. Newborn, they're asking 21 days. Nowadays, short is sweet, whether newborn or neutropenic, short is sweet. Even newborn also, previously people say meningitis, newborn, there is no blood-brain barrier, I want to treat longer. But now even for newborns or even for neutropenic, the duration is coming down. But newborn, there is no RCTs, but usually 10 to 14 days is fine, provided the newborn is improving. And again, people keep on asking about plasmolite, already answered the thing. And septic shock with acute with very good urine output, mild antibiotic doses. Usually, again, the dosing of the antibiotics, initial phases of sepsis with acute kidney injury, there's no need to worry about it. Because most of the nephrologists, what we encounter, they want to conserve the antibiotic. So what I will say, we need the patient should survive first. Then only the kidney. The kidney can be dialysable, but patients cannot be dialysable. So I need to have a live patients for kidney to function or kidney to be replaced or something there. So give a good dose of antibiotic. That's most important thing. So I sincerely thank the participants. Till the end of the presentations, almost 85 people are still there, even though we overshot it for 5 minutes. And I thank the presenter today to keep the engaged audience, keep on putting the questions till the end. This is a good presentations he made today. And I thank AP and ICP for giving this wonderful opportunity. These questions will be answered leisurely. This is only tip of iceberg. We need to read about sepsis. They showed a lot of guidelines, a lot of papers, everything you need to read about. On 30, 40 minutes, presentations won't solve anything there. You need to read about it. That's the point. And your post-test, not post-test, your certificate examinations questions will be based upon the presentations what the presenter has made. So think about it. We meet next week. Mostly fungal infections is a talk. I need to decide about the speaker and let you know that. Thanks for
Thank you, sir.
opportunity and thank you for your valuable time, Dr. Bukas.
Thank you, sir. Thank you very much, sir, for giving. Thank you, sir.
We are winding up now.
Thank you, sir.